Capsule Comments. Timely information from leading professionals on critical healthcare issues. A meta-analysis of diabetes-related studies helps confirm the value of diabetes-specific nutritional products. One of the principal authors of the study, Dr. Alan Sinclair, is Associate Dean and Professor of Medicine at Bedfordshire and Hertfordshire Postgraduate Medical School at the University of Luton in the United Kingdom, with Carolyn Alish, Senior Scientist, Diabetes Research and Development for Ross Products. Abbott Nutrition is proud to present Capsule Comments.
Thank you for joining us today. We have a lot of material to cover, so I'm going to dive right in there and go ahead and get started. The study that you published is termed a meta-analysis. Could you describe your study design for us?
Yes, well, a meta-analysis is a statistical process, often complex in its design, which attempts to combine the results of a small group of studies where the sample size is relatively low and insufficient to have a valid or reproducible end point. And in this process, by combining the results of a number of smaller studies which have a related or central research hypothesis which is similar, the strength of this weighted average, or sometimes we call it an effect size, is much greater.
What criteria did you use to include studies or exclude studies in your meta-analysis?
Well, we wanted to include studies that involved oral nutritional supplements or tube feeds. We wanted to include studies that compared diabetes-specific feeds with standard feeds. We wanted to include studies that looked at nutritional supplementation versus routine care. We wanted to obviously include patients with diabetes, both type 1 and type 2 diabetes. And we developed a set of criteria in order to compare and contrast each of the studies we were examining with the criteria for inclusion into our meta-analysis.
Professor Sinclair, could you define what a diabetes-specific product is?
There is no agreed consensus on the composition for diabetes-specific foods. But in general, the carbohydrate content is lower than in standard feeds, so it would be about 35 to 40%. And an increased proportion of fructose would make up some of the sugar content of that.
And why the fructose?
Fructose has what's called a low glycemic index, so that when it is absorbed, the peak glucose response that follows the digestive process is lower than in other types of sugar moieties. Diabetes-specific foods also contain a higher proportion of fat, 45 to 50% of fat. And the majority of that fat would be monounsaturated fatty acids, sometimes termed MUFAs. Diabetes-specific foods also contain a higher proportion of fiber, and nutritional companies often add other products such as soy protein and antioxidants to enrich the nutritional value of a diabetes-specific product.
So when it comes to diabetes-specific products, many clinicians are concerned about the relatively high level of fat in the diet. And if I'm hearing you correctly, we really need to look at what the composition of that fat is. And in many instances, high monounsaturated fats is beneficial.
What we do know is that in some of the studies that when you give high concentrations of monounsaturated fatty acids, there are some studies to suggest that the myocardial infarction rate in patients may actually decrease. So overall, if you try to assimilate all that information, you would say that you have a degree of confidence in using this approach, that there may be cardiovascular benefits.
Your research had some significant findings. Would you share with us what those findings are?
There's an increasing recognition that having high circulating levels of glucose is bad for you, especially in patients who may have a critical illness, patients who have a myocardial infarction or a stroke. These sorts of patients, we know that improving the level of glycemia, lowering the glucose level, there may be clinical benefit. We know, of course, that many patients with diabetes, especially type 2 diabetes, are admitted into hospital with a number of significant vascular complication problems, infection problems, and that they require nutritional support. The fact is that many patients with type 2 diabetes have evidence of nutritional impairment. And therefore I think it's vitally important to recognise that those sorts of patients do need not only some form of nutritional intervention, but they do need to have an intervention that does not upset their metabolic control. Our meta-analysis in which we examined the comparisons between diabetes-specific feeds, either given as oral nutritional supplements or tube feeds, compared with standard feeds, showed significant improvements in postprandial glycemia. There was a fall in glucose of at least 1 millimole per litre.
And that's translated into 18 milligrams per deciliter, is that correct?
Yes, I believe so. And this by itself does not seem large, but in a population of patients with type 2 diabetes, that may be associated with significant vascular benefit in the long term. There was also a decrease in the peak glucose concentration of about 1.6 millimoles per litre.
Can you tell me what you mean by peak glucose concentration?
It's the highest level of glucose that is achieved following the meal or the feed. And the glucose area under the curve is also much lower, and that over a broad space of time, that's also an important finding. So in terms of glycemic change, there were significant benefits, which we feel could be translated in a broad context with vascular benefit if this were over the longer term. We must recognise that in our meta-analysis, none of the studies were more than 3 months in duration. Quite a significant number of studies were single meal studies, and I think only about 7 studies were longer term, that is between about 6 days and 3 months. So as I've indicated before, longer term studies are definitely needed. Now the second important finding that we observed was that there were no significant adverse changes in the lipid profile. I mean, one might argue that with a lowish carbohydrate content in the diabetes-specific feeds, that we might have seen a reduction in triglycerides. But I think we have to accept that when we lower carbohydrate content in these feeds and increase the fat content of the feed, it's like a balance, it's an offsetting one with the other. And in my view, it's only in very low carbohydrate diets, when you get to the percentage less than, say, 20%, 25%, that you'd start to see significant benefits in triglycerides.
Your study uncovered some significant findings in terms of improvements in glucose control and no detriment to blood lipid levels. What other benefits did you uncover with the use of diabetes-specific products, say, over a standard nutritional oral or tube feeding product?
Well, I think there were 2 main categories of additional benefits that we determined. Unfortunately, both of these were not able to be part of the full meta-analysis program. These were findings that were indicated from our examination of individual studies within the meta-analysis. I think the first most important finding was that diabetes-specific foods were associated with a decreased requirement for insulin therapy. Now, in some studies this amounted to a difference of, say, 6 units per day between the start and end of a study, or equivalent to about 26% difference between diabetes-specific feeds and control standard feeds. So that was an important finding. This was especially important in patients with critical illness. And the reduced requirement for insulin obviously has benefits in reducing the incidence of hypoglycemia, a low glucose level. The other important category of benefits relates to a decrease in the incidence of infections. Again, this was noted in individual studies, not in the full meta-analysis. So this ranged from fever, urinary tract infection, pneumonia. So these are actually very important benefits that, if these could be consistent findings in patients given diabetes-specific feeds, then they would be of immense clinical value.
If you were to measure quality of life in a tube-fed population, what do you think you might see?
This was an issue that we were concerned about when we were preparing the meta-analysis. The study panel, were very keen to include this as an important outcome measure. But unfortunately, there was no consistency in the quality of life measures used in individual studies. So we weren't able to include it as part of the full meta-analysis. But quality of life is an important issue in patients with diabetes.
Just to generalize, what would be your optimal formulation?
What we do know is that we need about 18 to 20% of protein generally in the feed. This therefore meets the synthetic and anabolic needs of an individual. And in patients with acute illness, their catabolic needs need to be addressed, and therefore that sort of composition of protein is going to be essential. We've already stated that diabetes-specific feeds have higher concentrations of fat, mainly monounsaturated fatty acids, lower concentrations of carbohydrate, and higher concentrations of fiber.
There seems to be two schools of thought when it comes to providing enteral nutrition products to patients. The one school advocates for the use of diabetes-specific formula, and the other school would prefer to use a standard formula and then manage the patient's glucose level with insulin. How would you advocate for the nutritional approach?
It's fairly true that a number of physicians, clinicians, prefer to manage glucose levels with insulin using standard feeds, and as long as those target glucose levels are achieved, they seem to be quite happy with that approach. I think that approach is partly based on their perceived need of a lack of consistent benefit in using diabetes-specific feeds, presumably on published evidence. And also perhaps they have concerns about the costs of using that approach. But in view of our meta-analysis and in view of increasing evidence from other studies, I think there are advantages of using diabetes-specific feeds. We could offer this approach very much not only on the nutritional but on the metabolic level, because of these added benefits we've seen in reducing glycemia, no adverse effect on the lipid profile, and of course effects such as a reduced insulin requirement, lower infection rates. Well, these must be very important issues that cannot be easily dismissed in patients with diabetes.
So to summarize, what arguments do you have for the use of diabetes-specific products over the standard nutritional product?
We may anticipate longer-term benefits. Longer-term benefits would relate to a lowered incidence of vascular complications. The overall morbidity profile would be much lower. Survival may increase. But these are longer-term benefits that we would need to study.
What kinds of patients would benefit from these products?
Older people in general, certainly those patients who have a moderate to severe amount of frailty or nutritional impairment, they would benefit. Patients undergoing surgery or post-surgery would benefit from this approach. Patients with neuropathic ulcers, patients with pressure sores, and those patients that attend the orthopedic department, for example, for fractured neck of femur, these also potentially would benefit enormously from this approach. So as you can see, the 5 or 6 categories of patients that straight away may benefit. And of course, we then have the often neglected but considerable population of residents of care homes, nursing homes.
As a diabetes expert, what impact does your publication have in the area of specialized nutrition?
I think a meta-analysis of this kind should be a stimulus to further research in this area. It's enabled us to identify gaps and deficiencies in the research methodology that's been employed up to now in these dietary intervention studies. For example, we've seen a lack of consistency in the outcome measures used. We've seen a lack of focus on issues such as quality of life or cost effectiveness. And we've seen a lack of studies looking at basic science changes such as immune function and the role of these types of interventional studies. So a meta-analysis is an important tool not only for stimulating research in this area, but for advancing our knowledge of the effects of dietary intervention.
Thank you so much for joining us today, Dr. Sinclair, and for sharing your expertise and your perspective on the use of diabetes-specific formulas. Diabetes is certainly a healthcare issue today that is a global one. And I believe that your research has uncovered some significant findings that hopefully clinicians will benefit from using in their daily practice.
And it's been a pleasure speaking with you this morning as well. Thank you.
Thank you.